Hello everyone, I hope you are doing well. Before we start, just a quick thank you for the 84 subscribers. I really appreciate the support. Today we are going to talk about a cancer that is well known for its poor prognosis, glioblastoma. As you can see here, the slide shows the 5-year survival for different cancers. Glioblastoma isn't specifically shown, but its prognosis is very poor, with a 5-year survival below 10%, sometimes closer to 5. That makes it comparable to one of the worst prognosis cancer, pancreatic cancer. Glioblastoma is a rare cancer with an incidence of about 2 to 5 cases per 100,000 people. It's the most common malignant tumor in the central nervous system, and it's associated with a very poor prognosis, as I just said before. Clinical presentation is often progressive and depends on the location of the tumor. Common symptoms include headaches with nausea and vomiting, cognitive decline, personality changes, visual disturbances, speech difficulties, motor weakness, sensory deficits, and seizures. These symptoms usually reflect increased intracranial pressure or focal neurologic involvement. On MRI, glioblastoma has some very characteristic features. We typically see a ring-enhancing mass with central necrosis on T1 with contrast, surrounded by extensive edema on T2 flare. This often causes a mass effect, sometimes with a midline shift, and with advanced imaging, we can see a hyperperfusion reflecting high tumor vascularity. Surgery is the first step of treatment. The principle is simple: the more tumor we can safely remove, the better the outcome. The goal is maximal safe resection. Today, the diagnosis of glioblastoma relies on molecular criteria. It is based on the presence of IDH wild-type status and at least one of the following features: microvascular proliferation, necrosis, third promoter mutation, EGFR amplification, or chromosome 7 gain with chromosome 10 loss. MGMT promoter methylation is a good prognostic factor in glioblastoma and is associated with a better response to temozolomide. Since 2005, the standard of care has been maximal safe resection followed by chemoradiation. This consists of 60 gray in 30 fractions with concomitant temozolomide followed by 6 cycles of adjuvant temozolomide. In practice, the STUP protocol is not suitable for every patient. Treatment has to be adapted based on the age and performance status. I've summarized the main strategies in this diagram for those who are interested. In clinical practice, two main philosophies dominate target delineation in glioblastoma, mainly differing between the US and Europe. In the US, the most commonly used approach comes from RTOG-based guidelines. It typically uses a two-phase strategy: an initial larger volume, including the resection cavity, contrast enhancement, and T2 flare abnormalities with a margin, followed by a boost focused on the cavity and the residual enhancing tumor. In Europe, the Estro-EANO approach is more frequently used. This is generally a single phase plan based on the resection cavity and on the T1 contrast enhancing tumor with a margin. And sometimes it's including suspicious non-enhancing flare abnormalities. So overall, the US tends to favor a larger volume, two-step volume, while in Europe more often uses a single, more limited target volume. Radiochemotherapy can lead to several side effects. The most common include fatigue, hair loss in the treated area, nausea, hematologic toxicity related to temozolomide, and possible cognitive decline over time. Unfortunately, most glioblastoma will recur over time. The median progression-free survival is around 7 months, and most recurrences occur locally, typically within 1 to 2 centimeters of the original tumor site. At recurrence, prognosis is poor, and treatment options may include systemic treatment, radiation, and sometimes repeat surgery in selected patients. Despite standard treatment, outcomes remain limited, which is why new strategies are being explored. One of these is dose escalation, and this brings us to the Energy BN001 trial. Energy BN001 is a phase 2 trial evaluating dose escalation up to 75 Gray using proton therapy, and its results have led to the development of a phase 3 study. It showed a signal in favor of improvements overall survival with hazard ratio of 0.81 and an absolute benefit of about 6 to 7% at 2 years and around 4 to 5% at 3 years. This benefit may be partly explained by lower rates of severe lymphopenia observed in the proton arm. Thank you for watching. If you enjoyed the video, don't hesitate to leave a like and subscribe to the channel, and let me know in the comments what topics you'd like me to cover next. Bye!